name is Christy, and today we will be talking about the new transformative research of the uses of TDCS or transcranial direct current stimulation for those suffering with anorexia nervosa. We will be reviewing the literature by analyzing the transcranial direct current stimulation technique, its physiological effects, mechanisms, pathology of anorexia, treatment efficacy, gaps, and future direction for research. Let's get started.
Transdirect current stimulation is a non-invasive brain stimulation applied with a weak direct electrical current, typically 0.5 to 20 mA, through electrodes placed on the scalp in correlation with the brain's neural pathway of interest. TDCS works by modulating cortical activity through electrical current's ability to shift subthreshold resting membrane potentials through anodal stimulation, typically increases depolarization, therefore increases excitability. Cathodal stimulation typically hyperpolarizes the neurons, which reduces excitability in targeted brain area. Through these mechanisms, TDCS allows the brain to modulate synaptic plasticity, enhancing long-term potentiation or decreasing long-term depression of synaptic transition. These effects influence several neurotransmitter systems. TDCS's influence with psychiatric disorders, especially is in its infancy stage, particularly regarding anorexia nervosa. Initial work focused on substance abuse and behavioral disorders. TDCS is relatively inexpensive, easy to use, associated with minimal and transient side effects compared to other treatments. However, one case report noted that the onset of type 1 diabetes coincided with active TDCS, raising questions about possible effects on glucose metabolization in vulnerable populations, although the link remains unclear.
Anorexia nervosa is a serious, life-threatening psychiatric eating disorder. It is characterized by significant low body weight of below 18.5 kilograms per meter squared BMI, intrusive thoughts caused by intense fear of gaining weight, alongside a distorted sense of perceived body image. This accompanied by severe dietary restrictions or other weight loss strategies such as excessive exercise, dieting, as well as self-induced vomiting and diarrhea. Anorexia has the highest mortality rate among all psychiatric disorders, estimated to be about 5.1 death to 1,000 person ratio per year.
Anorexia is a biopsychosocial condition with psychopathological linked to excessive cognitive control, with patients often exhibiting increased hunger suppression ability. This elevated cognitive control over reward processing is observed even in recovered patients. Comorbidity anorexia is frequently associated with major mood, anxiety, and obsessive compulsive disorder symptoms. Also, the HPA axis, or the stress response, biomarkers like BDNF, neurotrophins, and cortisol levels are often dysregulated in anorexia. There is also neurobiological and structural changes to the brain area, such as the dorsolateral prefrontal cortex, linked to chronic starvation. The changes and dysfunction is assumed in the brain's reward and emotional systems, resulting in impaired balance between the interoceptive and reward processing and future dysregulation in the frontolimbic circuit associated with the habit formation and reward centers.
Currently, there is no gold standard treatment for adult anorexia, as reports indicate 70 to 90% of patients do not achieve full remission.
TDCS modulates the frontolimbic circuit associated with the impaired self-regulation, cognitive control, and reward processing in anorexia. An underactive DLP-FC could be responsible for higher cognitive control and emotional regulation, which may inadvertently be making extreme caloric restriction easier. So through TDCS excitation, theoretically, dietary restrictions can be reduced, restoring intrahemispheric balance of the hyperactive left hemisphere and the right hemisphere dominance can be shown on the screen through full ways. Alternatively, a pilot study investigating stimulating the left anterior parietal lobe, which may help with connectivity and multisensory integration and body image. TDCS can potentially increase release and uptake of extracellular dopamine in parts of the striatum, which is linked to anorexia's pathogenesis as it is in charge of the reward motivation network, thereby promoting food intake. The treatment efficacy of TDCS for anorexia is highly variable as it's dependent on the methodology, age, and outcome measures, and overall preliminary studies rely on small sample sizes and open-label studies, which suggest improvement in eating depressive symptoms in 7 patients after 10 sessions for 1 month. A current ongoing trial suggests active TDCS significantly reduced eating disorder symptoms, compulsive behaviors, and food control. Results regarding weight recovery is very inconsistent, with some studies suggesting significant improvement in BMI, like in adolescents receiving 18 sessions, and an 18-year-old female patient getting 2.42 kilos in 20 sessions. However, the first double-blind sham study on 43 adults found no significant effect on psychopathology or weight recovery (BMI), only reduced food control and body image. Concerns also exist whether excitation may amplify weight loss, but this question currently has no evidence.
Knowledge. The research field is limited because of methodological challenges and insufficient data, such as low quality and conflicting data, as literature consists of mainly case studies and open labels and small RCTs. Methodologies is highly diverse, including various protocols like the number of sessions, duration, target selection, and outcome measures. The neurobiological mechanism of anorexia is poorly understood, making it difficult to select the optimal stimulation targets, and lack of longitudinal data beyond 1 to 4 months neglects the nature of the condition. Confounding factors such as neurotropics and the client's metabolic and nutritional state might influence the response to treatment. For future research is to prioritize robust trials to confirm efficacy and clarify clinical implications, optimize protocols such as dose, frequency, duration, intensity, and target selection for TDMS, explore new targets such as the inferior parietal lobe, look at comorbidity symptoms, investigate mechanisms using imaging and cognitive tasks and biological markers, test combination therapies with such as CBTs or nutritional interventions with TDCS, look at more longitudinal studies with follow-up assessments extending over longer time periods, and see whether at-home treatments is feasible. The references used for this presentation. Thank you.